And I know that Darlene talked with you all about social transition, but I just wanted to touch upon social transition a little bit more. Social transition is not something that is only for young people. There are lots and lots of elements to it that many people who undergo transition may employ, such as changing one's clothing, changing one's name, maybe their pronouns, extended family, maybe talking to other people in your world, whether that be your place of employment or your school. Potentially other parents. I think that once somebody has undergone a social transition, if they're prepubertal, there are not really a lot of changes. And I think people have questions about what to tell other parents. Maybe the medical environments where that young person is getting medical care, so doctor, pediatrician, nurse practitioner, dentist, etc. For non-binary young people, they may not do any elements of social transition. They may change their pronouns to gender neutral pronouns. They may use the same name that they were given at birth. Sometimes there's mixed clothes. So I have a young person who, on some days wears more stereotypically feminine clothing, and on other days more stereotypically masculine clothing. They use all pronouns, and it really just varies. I have a little kid who does this and says, on the days I wear a barrette in my hair, use female pronouns. So there's lots of different iterations of what social transition may mean. These are just some of the things that people may employ to feel more comfortable. Many times when non-binary young people are talking about their gender or their gender is unfolding, which is really how I like to think about gender for people that are not cisgender, their parents and caretakers may feel like, please pick one. That's easier for us, which doesn't work for someone who's not in that particular space. What do we consider? I think, and I might have talked about this a little bit yesterday, but folks may know or may not know about the Cass report, which made a recommendation that if prepubertal children were going to undergo social transition, that they do it in the context with and alongside a clinician. I think that there's a lot of issues with that. And a lot of families, again, like I said yesterday, do this on their own. But I do think there are considerations if you're working with families, if you're a parent yourself. Safety is a really important thing to consider. And I think this is probably not different from a lot of navigation that trans people are doing all the time, is kind of balancing their own safety and their own personal health and emotional wellness. But safety really is a consideration, especially right now if you are in a state where trans youth care and trans experience and existence is being challenged and threatened. So safety is a really important aspect. Who are you going to tell and when? Who needs to know and who doesn't need to know? And then these are the different domains that we just talked about. I'm reminded of maybe about 15 years ago, there was a young person who lived in a very small rural community in California when her gender unfolded and she disclosed that she was a girl, and her parents were able to wrap their heads around what was happening. They fully supported her in a social transition. She was not yet in puberty, and a friend of mine bought her a pair of sparkly sandals, and she was elated, over the moon about this. And she left her house, and neighborhood kids threw rocks at her. And so I think that even though it is really unfortunate that we are in a more dangerous environment than we have been in the past, I think that safety is an important concern. the role of family support really cannot be overemphasized. There have been data that have demonstrated that family support is one of the most important factors for health and well-being of young people. So maybe supportive parents or caretakers that are living together or even in separate houses, let's find some clothes that make you feel the best, right? Let's support you and help you experience gender euphoria, which I'm going to talk a lot about today. On the other hand, I have many situations where parents are really struggling, and maybe one parent is on the page more closer to the child, but the other parent is not. And maybe one of the parents is rejecting, this is blaming the other parent or caretaker. This is all your fault. Get those clothes off of him. And that creates a really emotionally abusive situation for the child, because the child recognizes that their gender and their assertion of their gender is creating friction in the family. And so if there is friction, if there is disagreement among the parents or caretakers, it's really important that they take those disagreements into a space where their child cannot witness it. Now, that's really hard to do completely, because many of us wear our emotions pretty understandably on our personhood and our behavior. But I think when parents or caretakers need to resolve these differences and get into the same place, they need to do that with a couples therapist or with the providers that are going to be on that young person's care team, but specifically in their own space. Here's a study that was done that looked at the anxiety and depression of transgender prepubertal kids who were socially transitioned and supported in their gender. And what you see there was a control group of cisgender kids, and there was a control group that consisted of their cisgender siblings. And what you can see there is that the depression ranges are the same, not significantly different among these three groups, and that there is a little bit higher but not significant anxiety, which is not uncommon among people with gender dysphoria, or even people who just have a gender different than their registered sex at birth. So this is a little bit of really good information that came from Christina Olson, sadly no relationship to me, but who did this work in Seattle and has really expanded this care. Her team did a follow-up study that was published in 2022. They had 317 young people in that study. You can see that the majority were registered male at birth. The mean age of social transition was 6.5 years. The mean age at the start of the study was 8 years. And among those young people, there were 298 who, this is now about just under 4 years since they started the study, had a binary transgender identity, or an identity that was different than their registered sex at birth. 8 of those 317 had moved out of their gender diverse space and identified as cisgender, and 11 identified as non-binary. So these are some data that are contrasting to some of the old data, in which if somebody was registered male at birth and they wanted to wear dresses, for example, or play with dolls, they were brought to a mental health institution and then followed from there. But of course, as we said yesterday, there are many people who are gender expression nonconforming in childhood and are not necessarily trans. So when you look at those studies, they have much larger numbers of people who identified as cisgender later in their life. I think that the history is really critical, not just to understand the community, but also to understand the history of the care. And I think this is really important in our understanding of how we've gotten to where we are today. So what we know from history is that there have been trans people since people. And so there is anthropologic and archaeologic evidence to suggest this. There have been a few studies that have looked at specifically around artifacts and burials. So this was actually a statistical study of artifacts in burials right out in what we call today northwestern Iran. And I just pulled a few quotes from this article, but I can certainly put this on our list of references if you all want to look at it more. So there's one cluster of artifacts that tended to appear together. So needles, garment pins, jewelry, and those articles are invariably associated with skeletons that are biologically identifiable as female. There are another cluster that is like metal vessels, weapons, and armor, and those are strongly and statistically correlated with male skeletons. But the statistical algorithm that they used for these artifacts demonstrated that about 20% of those burials had a third cluster, which was, co-occurring of it mixed these two clusters of objects, and they accompanied skeletons of both biologically identifiable skeletons. And so this is, talking about like the artifacts that we're seeing. One male skeleton tomb included an arrowhead, which is traditionally considered masculine, and a garment pin, which Hassanlu's culture, is just about the most strongly feminine item there is. So there is archaeologic and anthropologic evidence that there have been people who have had this experience since there have been people. Now, what do we know about, like, not necessarily archaeologic, but maybe more anthropologic data, right? There are lots of examples of people who are cross-dressing or presenting themselves as a different gender in the Ottoman Empire. In the Civil War, there were 500 soldiers that at death were found to be registered female at birth. Amazing documentaries about people from that time period in mid 1800s to early 1900s who were transmasculine individuals, which is not often a history we hear a lot about. And I'll talk about that in a minute. Magnus Hirschfeld, many of you may know. So Magnus Hirschfeld was a doctor in Germany. And I think I talked about this a little bit, but especially if you read Straight Outta Germany, Magnus Hirschfeld was gay, and he devoted his scientific study to LGBTQ people and the culture, and used to hold these parties at his house. He wrote profusely about the experience of being gay and about trans experience, and had a pretty significant institute with all kinds of information that was burned down by the Nazis. And so I just think about this quote, which is from a podcast called Making Gay History. And it's this: he is the preferred hate object for the right wing, and especially then for the Nazis. He's constantly reading slander, Every morning he woke up and there was nasty, crappy, disgusting, anti-Semitic stuff above all being said against him. And 1920, he's at a lecture in Munich and right-wing thugs beat him up and leave him for dead on the street. He's bleeding. And then he's reading his obituary the next morning. So he didn't die, but he was consistently subject to the vitriol and hate of the group at the time. And I guess this resonates for me because this feels like where we are in 2024. Myself and many other providers of the care, and I know some parents as well, who get threatening letters, threatening to kill us, threatening to come and burn our facilities down. And so I feel like many things in human history, we are cycling always through these efforts to understand and liberate minoritized populations. But more importantly, I think than that is to understand that when the care and consideration and study of trans experience moved into the medical world, and primarily I mean the psychiatric world, this really was a white European experience. And so you have sexologists and psychiatrists all considering what is, the reason, the etiology, why are people trans, and what can we possibly do about it? And we see and filter through this sort of white psychiatric investigation of what was considered to be a psychiatric issue. These are some of the things that people have said in the past about trans experience. And remember that these ruminations about why people are trans are primarily coming from white Europe and over time into the United States. So this is what people would say. Profound disturbance of the mother-child relationship can often be empirically demonstrated and postulated to be the causative factor. Response to trauma. So in boys, in trans boys, it's said to represent an attempt to repair the defective relationship with the physically or emotionally absent primary attachment figure through fantasy. And in assigned girls, the motivation is the child's need to protect herself and her mother from a violent father by acquiring masculine strength for herself. So really important. These things are not true. These are an example of why we still have the vestigial tail of this kind of thinking when we're talking about trans care and trans experience. Standards of care came from this guy, Harry Benjamin, who was a physician that primarily worked in San Francisco. He went over to study with Magnus Hirschfeld. And in 1948, he was back in the United States. And his first patient that launched him into trans care was a 14-year-old. A 14-year-old who was registered male at birth, but wanted to become a girl. That's the quote. And this young adolescent rapidly led Harry Benjamin to understand that what we had been calling transvestism, or an urge to cross-dress or dress in the stereotypical garments of another person, because remember, you did your gender through clothing and occupation before there were hormones. And, Harry Benjamin was a psychiatrist, and despite the psychiatrist who he worked with, he also was an endocrinologist. He eventually decided to treat the child with estrogen, which he reported out had a calming effect for her and helped for the young person to go to Germany, where she had surgery. So I think, so Harry Benjamin began an organization that was later to become the World Professional Association for Transgender Health, which is what you see on this page. And the World Professional Association for Transgender Health, the Harry Benjamin organization before it was renamed, started creating standards of care guidelines for the care of what was then called transsexual patients. In 2009, the Endocrine Society, which is a worldwide society of endocrinologists, published their first treatment guidelines. And you can see those on the right. And I think that those standards of care have changed over time, but I want to show you some of the stuff that came from Harry Benjamin and also after that. So what Harry Benjamin is calling a classic transsexual, which is not language we hear a lot anymore, that people had a lifelong history of a desire to be of the sex opposite from the present anatomy, chromosomes, and endocrine secretions, that people manifested a gender behavior patterns opposite to his anatomical sex. And I want to talk about that because so much of this language is around trans feminine experience. Right. And so that is an important part of the history because trans masculine people were able to assert a masculine presentation much easier. So for example, the 500 soldiers that I was talking about in the Civil War, people bound their chest and then just put on like what was typically men's clothing at the time. And there are many historic, if you go back into the history, if you're interested in it, like I am, go back into the history, and what you see is that trans feminine people were often the folks who were brought in front of judges. And they were the ones that were sent to jail for disturbing the peace. And so transmasculine people were rarely found and brought in front of judges because the only reason they would be picked up would be if the police knew their family. And so then these folks would be brought in front of the judge, and the judge would say, you can't put this person in women's clothing. That would be a disturbance of the peace. Right. So going back to, and we're going to talk about this a little bit more when we look at the criteria for this diagnosis of gender dysphoria in adolescents and adults, because it really, really matters the way that we're talking about people and the experiences of trans feminine people versus non-binary people versus, trans masculine people. So manifest female personality characteristics, repudiates men's clothing, wears women's clothing, desires to be rid of the male genitalia, and is attracted to men in a heterosexual way. We could have a long talk about that later. And then no pleasure derived from the penis. So I think that's interesting also because we were codifying like to hate your body, your genitals, which is really, that's also problematic. Has the non-delusional idea that just even the language, that he is actually female, but is in a male body. Okay, let's look at what's happening in the United States around this time. Donald Laub and Norman Fiske were surgeons at Stanford in the 1970s. At this time, it was really becoming very, very common to have trans-related care across the country in different places. And so these two surgeons wrote this paper about folks coming for genital surgery, specifically trans feminine people. And this is the first sentence, which just is gobsmacking to me that you couldn't get something like this really published. But to change a person's God-given anatomic sex is a repugnant concept. And remember, these are surgeons doing this surgery, Morally and instinctively, it is difficult enough for a surgeon to perform an amputation of an arm or a leg. It is even more so to consider genital amputation and castration. When I first read this article, which was many years ago now, I was horrified and I thought, who could talk about this care in this way? And in 2024, people talk about the care in this way. It's an absolutely astonishing thing to be a part of this particular history in this way. And remember that now that we're talking mostly about trans feminine people, right? Because I don't think that folks would think about a hysterectomy or a vaginectomy in the same way that they think about vulvoplasty and vaginoplasty. In this article, and again, this is all to help inform why we are where we are. This is what this article says about therapy as an intervention. Allegedly, transsexualism, although basically a psychiatric condition, is paradoxically resistant to psychiatric help. So there are some pieces of this that are correct and some pieces of this that are incorrect, right? So the assumption that being trans is a psychiatric condition is not true. Whether it is resistant to psychiatric help is actually true. And I think this is important to keep in mind because remember that for a very long time, all people had as an option was psychological and psychiatric help, and it wasn't successful. So in 1973, Barlow, who was a psychologist and psychiatrist, reported that electric shock therapy and later modeling with videotape feedback was able to change the behavior in a 17-year-old. Okay, I don't think I need to explain that. That is just ridiculous. Child psychologist Richard Green, who's still alive, by the way, has identified the symptoms of transsexualism in young children, right? So trans adults started as trans kids. Not surprising that someone would see characteristics of this in a child. But this sentence, Green has made a plea to primary physicians to become aware of the implications of these symptoms because of the extreme difficulty the child will have in future adjustment. Green has begun active psychiatric treatment of transsexual children at ages even less than 6 to 8 years. Perhaps there is some hope for a non-surgical solution to this dreadful condition. This is the history upon which we sit and we're researching. I think in this article, there were listed requirements for surgery, which I think have had tremendous impact on the way that the standards of care guidelines have emerged over time, but certainly in their early iterations. So this is in order to have surgery to be considered like a gold star candidate for surgery, you had to demonstrate success in social, psychological, sexual, and employment spheres. You had to have 1 to 3 years of total cross living and working in the gender of their choice, right? So listen to the language and think about how it has impacted us. You have to have undergone successful endocrine feminization. So remember, these are not the requirements for getting hormones. These are the requirements for getting surgery. And freedom from psychosis or significant sociopathy, which is defined at the time as being in jail or being on drugs. Not married in the gender of your anatomy. Also discounts all of the trans individuals who identify as gay. And you had to be between 21 and 58. And the 2 life-limiting medical diseases that precluded you from having surgery, diabetes and hypertension. If you didn't meet those criteria, here's what you had to do to get surgery. You had to meet with a vocational counselor to find employment opportunities. You had to undergo job retraining. You had to work with a professional model to help you with grooming and counsel you in good taste and appropriate deportment. For trans masculine people, you had to work with a football coach, a physical therapist who directed a bodybuilding exercise and conditioning program. You had to undergo peer scrutiny via group therapy. And you had to live with one of the successful post-operative patients for several months in order to form behavioral identification patterns and learn tips for getting along in the desired role, as well as how to obtain food, clothing, and shelter. Oh, that's not all. If you thought that was all, that's not all. You had to work with a police department liaison to become acquainted with impersonation laws. So impersonation laws, it's very important for people to understand this. Impersonation laws came into being with colonization of the United States. So what happened is that people, when the tax collectors would come along, European colonists would dress up as native peoples to try and avoid being taxed. And so they put into place impersonation laws. So if you were caught doing this, you went to jail. But the impersonation laws were utilized to arrest and sometimes jail trans feminine people. And they utilized these laws that had to do with evading taxes to arrest trans women. You had to work with a professional attorney for document adjustments, and you had to work with an assigned counselor to provide advice regarding insurance, VA benefits, apartment rental, and you had to work with a counselor to learn how to avoid being labeled by the surgeon as excessively narcissistic, manipulative, or hysterical. Now, I mean, if the surgeon is labeling you as that, that seems like a surgeon issue, not really a you issue. There are obviously so many issues with this. And you had to undergo feminization with hormones. And you had to meet with a psychiatrist for a general needs assessment. The manuscript ends with this: to take advantage of the means to self-change, considerable conformity to standards must occur. Thus, behavioral modification, a psychiatric modality, is used to advantage as the patient rehabilitates himself simultaneously with his becoming qualified for the surgery in what they must present to the people who are going to provide them with care. It is a very, very narrow road to take. And so when we talk about, when we hear people say things like, are you trans enough? Are you this enough? Are you this enough? Right? Why are you, why do you want to be a boy wearing a skirt? Right? Come back to this. This is something that created an environment where people had to lie. Because think about getting all of those things in order. It's really hard to get employment if you were not able to access the things that helped you move along in the world as yourself. And we still struggle with these things now. There was a study that was done really pretty recently in the last decade where, trans people were asked, like, what's the most horrible thing that someone's asked you? And these were some of the things that people said, wow, I would have never known you used to be a girl. Did you have the surgery? So when are you really going to transition? Will you understand what it's like to be a woman? You will never be a real woman. Did you transition because you thought you were an ugly girl? You are so beautiful for a trans girl. So these are all the things that are still happening for people today. This is a community that has had harms perpetuated on it by family members, partners, peers, teachers, coaches, school counselors, religious leaders, religious communities, and religious beliefs, mental health therapists, sexologists, medical professionals, scientists, surgeons, legislators, lawyers, police officers, media, and this is a non-exhaustive list. I don't really know why my slide's not going. It's not about what's wrong with you. It's about what's happened to you. It's about the generational trauma that the trans community has endured. And it is that trauma that they carry with them that still these traumas that people are experiencing are still showing up in different iterations. When I first started this work, when I first started in my adolescent medicine fellowship, one of the things that I said during my interview is, I will never be a researcher. I only want to do clinical care. I have no interest in research. And as I started doing the care wasn't problematic or hard for me at all. I instantly understood it, but I also understood that there was not a lot of research. And so I became a researcher also, and started thinking about the data that cisgender people needed and the data that the community needed. I really thought that 18 years in my career, we would be able to work more on what the community was interested in. But unfortunately, we still are swirling around in the area of what people need, cisgender people need to help trans people get what they need and deserve. So I created a kind of map to understand kind of how some of these pieces and aspects of this care fit together in order to create a research protocol. So gender incongruence, which is the international code that's utilized in ICD-11. So there are ICD codes that people use in medicine and in mental health in order to appropriately document what people are experiencing and why they're coming in for care. Unfortunately, the United States does not use ICD-11. We use ICD-10, where there is no code for gender incongruence. But it is really important to understand that not everybody who has this experience of their gender being different than their registered sex at birth has gender dysphoria. There are people who have gender incongruence or trans that don't have gender dysphoria. But there are no people with gender dysphoria that don't have gender incongruence. And that's an important distinction, because gender dysphoria is the persistent distress, whether it be physical, emotional, mental, or other, about this gender incongruence that feels like a discrepancy for them. And so understanding that is really important. Factors that contribute to the experience of gender dysphoria have, and these are things that can both alleviate, like improve gender dysphoria, but also can exacerbate gender dysphoria, are both proximal and distal. So you have these distal factors in the society, like cultural transphobia or institutional cisnormativity, religious beliefs, legislative trans discrimination. And then a little bit more proximal to self, your family, your friends, your partners, your support groups that you have access to are a little bit closer to you. But there are also even more proximal factors like internalized transphobia or cisnormativity, people's own grief about their gender incongruence, uncertainty maybe about what their life is going to look like, the unfairness of it all. For some people, that plays a role, their own cultural and religious beliefs, and then fear. And these are all things that are going to exacerbate gender dysphoria if they are negative about trans experience, or they can actually mitigate gender dysphoria if there's, like, this is what we saw, that over time people were experiencing less of these things, and now we're in a space where they're experiencing more of them. So downstream from that, from a perspective of, of a researcher, We're thinking about the downstream mental health and behavioral outcomes. And I really want to note here that I think as a research society, we tend to focus on the negative things like anxiety, like depression, like social isolation and self-harm, suicidality, drug use, high-risk sexual behavior, because our goal as researchers, right, is to create scenarios where we can decrease those things. But I do think, and also in my studies, I incorporate scales of, happiness and satisfaction. And I think those are really important things to think about as well. Ultimately, we really want to improve people's quality of life. We want to improve their body esteem. We want to improve their coping skills. We want to improve their life satisfaction and their functionality. And so when I put together research related to are hormones good for people, this is what I think about that. There are many, many important things to research that have nothing to do with this and have to do with things that the community is interested in. And I'll talk about some of those things later. Right now, I have a multi-site NIH-funded R01 that's in its 9th year, and it is looking at many aspects related to this model. And one of the most important ones, one thing that we're measuring is appearance congruence. So all of the people enrolled in the study have gender dysphoria. We didn't enroll anyone who wasn't seeking medical care related to improving their gender dysphoria. So appearance congruence is a really important part of medical interventions. And what we have demonstrated is no matter how we cut the data and the different outcomes we're looking at, appearance congruence improves significantly across 2 years, across 4 years. And as we're collecting all of the later data, I'm sure that that will continue. So gender is an interesting thing. It can't be conceptualized as isolated. You can't pluck somebody's gender experience out of the world in which somebody resides, right? And so all of us send signals to the world around us about our gender, right? I am not a girl. Like this would be maybe a trans masculine experience. I am not a girl. Look at my flat chest. Look at my facial hair. Listen to my voice. Notice the bathroom I use. But there's also messages coming back from the world, both gender dysphoria exacerbating, but also gender euphoria, right? So maybe like, I love that you are comfortable as a man in a skirt. Oh, you have facial hair. You must be a man. Your voice is low. You must be a man. But also, men don't cross their legs. Your hair seems too long for a man. Why do you always use the stall in the bathroom? But maybe if somebody's been on testosterone for a while, they've developed an Adam's apple. Hey, look at that Adam's apple, right? So there's all, and this is like, right, 7. I mean, there are so many messages that are going back and forth between people and their environment. And that's why I think this is an important concept to understand, that part of feeling good about yourself and about how you feel related to yourself is that you are being perceived as yourself. That's an important part of care, medical care. And so many, many times people will say, why do you have to capitulate to the society around you? Why can't you just be the gender that you are in the physicality that you have, right? And this is the reason why, because you don't exist in a vacuum. We're not in a society that is, a gender utopia yet. We might be there at some point, but we're not there yet. And so because of that, because of this relationship that I'm trying to demonstrate with these less than adequate PowerPoint smart charts, is that this is all existing and being navigated at once. Okay. Let's talk about care from a developmental perspective. Prepubertal youth there is no medical intervention. I cannot say this enough times and emphasize this enough. If somebody has not started puberty, there is no medical intervention. We are not giving 5-year-olds hormones. We are not doing surgery on adolescents. We are not doing surgery on prepubertal children. This is a myth that is out there that is grossly incorrect. As people move along in their chronologic and their developmental stages, and they get to the beginning of puberty, they may be good candidates for puberty blockers, which I'm going to talk about at our next session. And once people or young people are in puberty or beyond puberty, they may be good candidates for gender affirming hormones. Now, I have to tell you that it is extraordinarily rare that somebody engages in care with a medical provider at a young age. It's even rare for someone to come around the beginning of puberty. And so as this whole furor happens around it's the children, recognize that it's mostly adolescents and young adults. So in my clinic, the average age of people seeking care is around 15. And so I'm not seeing a lot of 8-year-olds or even 12-year-olds. And that matters. And I'll share some data with you about that in a minute. You can also think about the phases of transition like this. So reversible phases of transitioning or steps in transitioning are the elements of social transition that we talked about earlier, and puberty blockers, which are also reversible. For partially reversible interventions, gender affirming hormones and some surgeries. So once you start gender affirming hormones, there are aspects of hormones that are permanent once they happen, but many of those changes are actually dependent on ongoing use of hormones. And really, genital surgery is a pretty permanent surgery. I mean, I think that there are things people can do, but they're in general pretty difficult if somebody wants those surgeries reversed. So how do people come into care with me? Some people come in and their gender unfolded very early in their childhood, and they went forward and had parents or caregivers listening, and they underwent social transition. But that's not the majority. The majority are people who they understood their gender early, and they did not undergo social transition in childhood. That's the majority of people. There are a group of people who assert their gender, or they put their gender puzzle together as puberty started, because it became clear to them that the development their body was going through was not in alignment with their gender. And this is really especially true for trans masculine young people. And the reason why is because the very first part of puberty for a trans masculine individual, a person with ovaries, is chest development. And so now suddenly you're developing something outside of your body, like sort of a outside presentation that is distressing for you. So I think this is one of the reasons it never gets talked about, but I think this is one of the reasons that we have a lot of trans masculine young people coming in for care around the beginning or slightly after or in the middle of puberty, because that particular pubertal development is really bad for people. And then we have, as we just heard, a person beginning their transition at 88. So that person could have any number of experiences in their past. Maybe they knew that their gender was different in childhood, but they just sort of tucked that away and didn't really talk about it until they were much older. There is, all of these pathways do not create a scenario that one person is more trans than another person. All of these pathways are possible pathways. Let's talk about numbers, because numbers, as you know, I think I said this yesterday, are really important. In 2017, people got really, really anxious about the uptick in people presenting for care, particularly in adolescent clinics. And so there was a group called the Kimono Group that did an investigation on the numbers of people, particularly adolescents under 18, receiving care. Because 2017 to 2021, well, they did the study in 2021, which is why that was the end date, but they really wanted to investigate this huge upsurge in the number of people who were getting trans-related care. And this is what they found. In the US, patients between 6 and 17 with a prior gender dysphoria diagnosis that initiated puberty blockers in each of these years. I just want to draw people's attention to the fact that that is like 5,000 people total on blockers in the United States, total. And then they looked at how many people got hormone treatment, and this, nobody at 6 got hormone treatment, but this was the way these numbers rolled out. And this ended up being about 14,000 people. I want people to understand that we have court cases in 23 states about this issue. Total, there are about 17,500 young people under age 18 getting interventions for gender dysphoria. 17,500. I don't know if anyone in this audience knows or can Google quickly, but I'll tell you so you don't have to do it. How many people in the country are under 18? There are 52 million people in the United States under 15. 52 million people. And 17,000 of them are getting medical interventions related to gender dysphoria. That's all. That's all. So what does that tell you? Also, I didn't put this up there, but 137,000 people had gotten a diagnosis of gender dysphoria, but only 17,500 were treated. What does this tell us? This tells us that we are grossly underserving the population of trans youth. That's the first thing it tells us. And it also is an indicator that people are being extremely careful about treatment. And I can't state this enough, because there is a trope about careless treatment in the United States of young people, that people are willy-nilly throwing up a shingle and giving kids hormones. That's just simply not borne out by the numbers. And I think that, again, I think I said this yesterday, but you know, when you say there's a 3,000% increase in the clinic referrals, but they only started with 30, that's not a lot, right? And so that number is easy to use against care, but this is the actual reality. It also tells us that actually not everybody in your kid's Girl Scout troop is trans. Even though you say that, think that, there's a lot of people who say that and think that. I'm going to talk about that phenomenon in a minute. What about chest surgery? There's the number of people under 18 who got chest surgery in these years. This is a really, really small number, especially given that the numbers of people pan out to be about 60 to 65% transmasculine of the people that are getting referred for this, right? Okay. I'm going to share some of this later with you. I have 3 minutes, but I'll definitely talk about this, that there are differences in the trajectories of people who are talking about their gender in childhood versus people talking about their gender in adulthood. And this is primarily what I see So when a kid is talking about their gender in childhood, it starts with somebody like that kid I described that was like tearing down the wallpaper, and she was like a mess, right? And so that was sort of the beginning of her talking about her gender, maybe distress around different toys and clothes and stuff. And if somebody undergoes a social transition, they have a bit of a honeymoon period because of hat and handbag, right? So we talked about this. And then when puberty starts, some of those young people are sort of experiencing a dip or a decline in their mental health because they now are going to be faced with this decision about whether or not to do something about their gender. And then their integration of their trans identity follows. For adolescents and young adults, they often will say I had a gender neutral or maybe a girly childhood for a trans masculine kid, and then puberty happens, they experience distress around puberty for reasons that we just talked about, but they have this period of integrating what's going on for them, right? Which is we call the coming in process. And then they come out and they start or seek medical intervention. These are two trajectories that I hear a lot for transmasculine kids. Oh, my kid was so happy. He was the sunshine of everyone's life. And then we don't know what happened at 11. Well, at 11, what happened was puberty, right? And so there's this time period of coming in. A lot of our kids try on girl, like, oh, I really girled it up for this summer and I, grew my hair long and all this stuff. And it's usually an epic fail. And then they come out and then they come to my clinic. For a lot of trans young people, trans feminine young people will have a history of, I always knew something was different about me, but I didn't know what it was. And then a period of coming in and recognizing that something's going on around sexuality or gender. And a lot of my trans feminine young people also will try on boy. So this idea of like trying on your expression or presentation of yourself aligned with your sex designated at birth is really common. I don't know why I have phenotypic transition in there twice. That's weird. Okay. So I have to stop and hand it over to Darlene. So I will pick up here and talk about puberty blockers at my next session. So thanks.